Again, today's Wednesday webinar is going to be about rooming in, so how hospitals are reaching 80%. This is something that hospitals really struggle with when they are adopting the 10 steps to successful breastfeeding, so I think today's topic will be really interesting to a lot of you. So today, when you're on the call, if you can press *6 to mute your line, and then if you press *6 to mute yourself, if you want to unmute yourself, you're going to press #6. And then we also request that people please do not press hold and place your phones on hold while you're on the webinar, or else we will all hear your lovely hold music. So before we get into our 4 hospital presenters, I just have a few updates from CHAMPS for you all. So there are a few upcoming CHAMPS 4-hour clinical skills trainings in Mississippi. The first one is at Gilmore Memorial Hospital on Monday, June 25th. There's going to be a morning and an afternoon session. Registration is going to open up to all other CHAMPS hospitals and CHAMPS community members on May 25th. The next training is at Ocean Springs Hospital on Thursday, June 28th. Again, there's a morning and an afternoon session for this training as well, and that training will open up to all of CHAMPS hospitals and CHAMPS community partners on May 28th. And you can register for the trainings by visiting our website at cheerequity.org/trainings, or if you'd like more information, you can email champsbreastfeed@gmail.com. We also have one more upcoming Wednesday webinar from our spring 2018 schedule. It's going to be on June 13th, and it's about the dissemination phase audit tools, so some tips, tricks, and best practices from hospitals in Mississippi. Then there's going to be a break in the webinars over the summer, and a new series will start in September. So if there are any topics that you would like covered in our Wednesday webinar series, you can email your ideas to champsbreastfeed@gmail.com, or you can talk to one of your CHAMPS hospital coaches about your ideas, because we'd love to hear them. All right, so now we're going to start the webinar about the rooming in and how hospitals are reaching 80%. We're going to have 4 hospital team members who are going to be presenting their experiences with rooming in. We'll have Linda Tuggle from Methodist Olive Branch Hospital in Olive Branch, Mississippi. We'll have Alice Cheney Herndon from University of Mississippi Medical Center in Jackson, Mississippi. Next, we'll have Susan Carbajal from Ocean Springs Hospital in Ocean Springs, Mississippi. And finally, we'll have Shannon Grosh from Toro Infirmary in New Orleans, Louisiana. So we'll have all 4 of those hospital team members present, and we'll hold questions for the end of the webinar. But if you have any questions that come up while the presenters are presenting, feel free to enter them into your chat box, and then I can ask them for you at the end of the presentations, and you won't forget your questions while you listen to the rest of the presentation. Okay, so I just wanted to read through the baby-friendly guideline for rooming in quickly before we start our presentation, just to refresh anyone's memory in case they forgot what the definition is or if you haven't heard it before. So the definition for rooming in is the facility should provide rooming in 24 hours a day as a standard for mother-baby care for healthy-term infants, regardless of feeding choice. So when a mother requests that her infant be cared for in the nursery, the healthcare staff should explore the reasons for the request and should encourage and educate the mother about the advantages of having her infant stay with her in the same room 24 hours a day. If the mother still requests that the infant be cared for in the nursery, the process and informed decision should be documented. In addition, the medical and nursing staff should conduct newborn procedures at the mother's bedside whenever possible and should avoid frequent separations and absences of the newborn from the mother for more than 1 hour in a 24-hour period. If the infant is kept in the nursery for documented medical reasons, the mother should be provided access to feed her infant at any time. All right, so without further ado, I'm going to hand things over to Linda Tuggle who will present on rooming in at Methodist Olive Branch Hospital.
Hey, hello, everyone. Just to kind of give you a little background about Methodist Olive Branch Hospital, we're located in Olive Branch, Mississippi, and we are a 100-bed community hospital that was built in July of 2013. Methodist Olive Branch is part of a 5-hospital system. It's called Methodist Sabona Healthcare, and it's located in Memphis, Tennessee. Our facility serves the North Mississippi population and some West Tennessee and Northeast Mississippi patients. The maternity center at Methodist Olive Branch started out as a 6-bed LDRP with a level 1 nursery in February of 2014. A needs assessment was done within the community that recognized the need for a level 2 nursery and additional postpartum rooms to accommodate our patients. These renovations took place in 2016, which then added 6 postpartum rooms and a level 2 special care nursery. After the renovations, the model of care changed from traditional LDRP to labor and delivery / postpartum. The center has also recently switched from traditional postpartum care to couplet care. We staff the maternity center with labor and delivery nurses, NICU nurses, and OB techs. And on average, the center delivers about 50 births a month. These deliveries are done by 4 hospital-owned OBGYNs. And intensive neonatal care is delivered by neonatologists and nurse practitioners that are housed in our Memphis facilities. Newborn care is delivered by 10 local pediatricians with hospital privileges. You can advance the slide, please, Laura.
Okay, you might, I gave you presenter privileges. Are you able to click on the arrow at the top of the screen?
Let's see. I am.
Okay,
great. Thank you. So prior to our facility joining the Baby Friendly Initiative, our pediatricians were assessing all newborns in level 1 nursery, and nursing staff were conducting all newborn screening in the level 1 nursery. So a culture change was definitely required to get our pediatrician physician partners on board with Baby Friendly. We have 3 pediatric groups with privileges, like I said, that make up about 10 physicians. One group in particular was seen as requiring a more robust approach to implement this change. With some insight into this becoming a barrier to our success, the Baby Friendly Task Force offered the lead pediatrician from this group to join our committee and serve as a physician champion. With this pediatrician serving as lead partner of this 5-physician group, we knew this key stakeholder would require buy-in for the rest to follow. So as a traditional practitioner with the mindset that every infant should be assessed in the nursery, we had to really do some robust communication with this physician. He felt he could assess and diagnose conditions more readily under the, quote, better lighting of the nursery. Well, we all know that the lighting in the mother's room allows ample opportunity to assess and treat her, so therefore we knew we could perform a pretty thorough exam on our babies. So we didn't allow him to use this excuse for very long. As I said, the transitioning was tedious. At first, he requested every newborn to have their initial assessment done in the nursery, and the subsequent ones could be done at the bedside. So we allowed this for about a month until we stood steadfast on the process of performing all assessments at the bedside. The nurses assisted with this change by going to the bedside when the pediatricians made rounds so they can make themselves available to readily address their concerns. As the clinical director, I reached out to the pediatricians and asked them what it would take to make their life easier and for us to get their assistance with achieving this goal. And they stated that if they had just had another ophthalmoscope and a nurse to assist them, that they would do it. So we were thrilled that this was all it would take for them to conform. So, of course, I purchased another scope, and we were on our way, or so we thought. We never imagined we would experience pushback from our own nursing team. A few of our SAGE nurses, who deemed themselves as owners, for lack of a better word, of the babies, couldn't see why she wasn't allowed to keep all her babies lined up in the nursery for her viewing and care and dispense them to their moms for 2 to 3 hours of their 12-hour shift to bond with them, with their babies. So this took a group effort from the director and fellow team members, pushing these SAGE nurses to join the rest of the team. These same nurses also complained about not having all the supplies and equipment needed for the 24-hour screening. They said they had to go in and out of the room too often, and this was disruptive and taking time away from their care. So we solved this problem by making our portable hearing screener all-inclusive, as you can see. So we added several trays to the bottom of the rack that contain a ProPack for CCHD, a mini IV start kit for collecting the PKUs, and any other labs that were ordered. And we also collect CMVs on all of our babies, so we added a box for those. And so the only thing missing from the cart was the transcutaneous Billy meter monitor. So we have that housed in the nursery. And this cart is also housed in the nursery. So when the nurse goes to retrieve it, she can then retrieve the TJM and have everything that she needs to perform the 24-hour screening at the bedside. So this cart, along with educating and just communicating with our patients and their families, has contributed to our success. You know, there was one concern that we wouldn't be able to perform, you know, hearing screens at the bedside because of the noise from guests in the room. So I don't know if you could see it, but we made a little sign that we simply put on the door when we're doing a hearing screen, and we educate as they hit the door about all of the processes and procedures that they'll be going through during their stay with us. So this has really helped us to be instrumental in our success. So now the only thing that's done outside of the room are circumcisions. And our next steps is just to continue to constantly communicate with the family and educate our patients so we can continue to be successful. That's the end of my slide.
Great. Thank you so much, Linda.
You're welcome.
I'm going to turn things over to Alice Cheney. So you should be able to advance the slides now.
Okay, good morning. My name is Alice Cheney Herndon. I'm the nurse manager for the Mother-Baby Unit and WIC Lactation Services for UMC in Jackson, Mississippi. Here's just a little bit about our hospital. We were actually designated baby-friendly in September of 2017. So we are continuing to work and meet metrics, but we're really proud of all of the work that we've done. We are the state's only academic teaching facility and the tertiary care center for the state. You'll see we have the only level 4 NICU in the state, so all of the babies out in the state that are sick are sent in to us. We have a 31-bed mother-baby unit. So we are on the 3rd floor in the Weiser Hospital. Down from us, off of the mother-baby unit, there are 15 intermediate care beds. Those are monitored beds for infants there. And we also have a newborn nursery. We have not gotten rid of a nursery. We use that for babies that are feeder growers that will come up from the NICU that have been separated from their moms and are feeder growers and don't really need an ICU bed anymore, but still are needing some closer monitoring and not ready to go home. So that's down from 3 Weiser. We also have 10 LDR rooms on labor and delivery, 3 OBS rooms, and then 2 ORs that are specifically dedicated for OB patients. We deliver about 2,300 babies a year here at UMC, so we are very busy. In addition to that, we have 3 prenatal clinics that feed into us, as well as a resident-run clinics that our residents, they see patients. It's down from our high-risk clinic. It's at the same location. So we have numerous different avenues of patients that are fed into us. So before Baby Friendly, all of our babies in labor and delivery went straight to the warmer. There was a high-risk nurse from NICU that attended every delivery. They would stand at the foot of mom's bed, ready to catch the baby with blankets, and the OB would hand the baby off, and the baby would go straight to the warmer to be assessed. There was no immediate skin-to-skin. Mom may get to see the baby if the obstetrician held the baby up for a second and let her glance, but then that baby was immediately whisked to the warmer in the room with mom. The baby was assessed there. The physician team came in the delivery. They assessed the baby at the warmer, and then, you know, sometimes 10 to 15 minutes later, the baby would get returned to mom. So At that point, usually after mom was cleaned up in a vaginal delivery and back in the bed was when she would get her baby. Baby may spend an hour in there with mom, and that was if mom requested. The babies were generally whisked away to transition nursery, which was on a different floor, and they spent anywhere from 4 to 6 hours there before they were returned to mom. So mom would have to specifically request if she wanted the baby to stay in the room with her, and would have to request to have we would call them an in-room, a private transition. So all of this was before Baby Friendly. So after Baby Friendly, lots of things have changed. So we had nurses that had always taken care of just moms, and they now had to take care of moms and babies. Nurses that had never had anything to do with the babies now had to be competent to take care of these babies and keep them out in the room with them. One of the things that really helped us was the implementation of a transition nurse role. So we have 4 nurses that do that. We have 2 on days and 2 on nights, and their role is to come in 30 minutes after the delivery. So we still have a high-risk nurse that attends the delivery, but the transition nurse will come in usually around the 30-minute mark. Sometimes they're there at the beginning, but they are solely dedicated to that mom and baby for that initial transition period, anywhere from 2 to 4 hours, just depending on how long it takes the baby. And they do everything at the bedside with mom. That has been a huge help for us. It has helped us improve our skin-to-skin and our rooming in tremendously, both skin-to-skin in PACU and then also for vaginal deliveries. So mom delivers on the 2nd floor of Weiser, and then she's brought up to the 3rd floor of Weiser. And mom and baby travel as a pair, travel as a couplet. Sometimes baby is in mom's arms as they travel. Mom's holding them. Sometimes the baby's in the crib right behind mama, but they travel together. So tips and tricks for us, this was a huge, like I said, it was a huge culture change. There was lots of education that had to go on with the staff. The nurses that had been postpartum nurses, again, they had to learn everything about the babies. The nursery nurses had always taken care of the babies, and moms would have to request for the babies to stay out in the room. Kind of like what Linda was saying, you know, the nurses were used to having their babies lined up in the nursery, and that's not the case anymore. So we really had to focus on the prenatal clinic, on the prenatal side, to let the moms know what to expect when they got to the hospital. I feel like that is one thing that we continue to work on, is educating in the prenatal setting so that when mama gets here, they do know what to expect. One of the things that's tricky for us is because we are the tertiary care center, we have moms that are transported in from all over the state, and they may not know what to expect when they get here. So that's one thing that we continue to work on, is as soon as they hit the building, whether it's through Women's Urgent Care, which is our OB emergency room, or whether they're direct admit to labor and delivery or the mother-baby unit, to really let them know what to expect during their hospital stay. We really have seen moms embrace the rooming in. They really enjoy it for the most part. We do have moms that I think are terrified of it, just to be perfectly honest. And that's why I said, you know, allow moms time to ask questions and encourage the moms. Let them know that you are here to support them, that you're here to help them. Some moms come in and are so fearful that they're going to be tired and exhausted and that they can't take care of their baby. And just having that communication one-on-one with their nurse has been really helpful to let them know that they can be successful with this. Another thing that we try to encourage all the moms is to make sure that they have a support person with them at the hospital, especially these moms that have a primary section or a repeat C-section. It's important for them to know, you may not be able to get up right away because you're going to have a Foley in, and you need somebody out in the room with you that can help you. So that's another thing that's been really beneficial, is if they have a support person in the room with them, we can educate the support person to be able to help with that baby out in the room. So we, another thing just to mention, we did have to work on our EPIC build. EPIC is our electronic health record that we use, and we needed to work on that because there were times that the babies prior to Baby Friendly were, you know, in and out of the rooms, and in order for us to really be able to track it and see how much time they were spending away from mom's room, we needed to have that EPIC build to be able to see the time that they left the room and the time that they returned. But I'm happy to say that for the past 3 months, we have had 100% rooming in at UMC, and this is, of course, for healthy babies, healthy moms that are term. We do have babies that have glucose issues. Those babies are out in the room with mom. So we encourage rooming in. We're doing a really good job with that. This is actually a picture prior to Baby Friendly. This was in 2012. This is my oldest son, Parker, and my new baby, Anderson. And I had to request for Anderson to stay in the room with me the entire time after I delivered him. And he did. He didn't go back to the nursery. He stayed out in the room with me, but that was definitely not the norm in 2012, and it is now. And that's all I have.
Thank you so much, Alice Cheney.
Thank you.
So we will, I'm going to change our presenter privileges to Susan. Let me find your name, Susan. All right.
Oh, here we are. Okay. I'm Susan Carbajal, and I work in the newborn nursery here at Ocean Springs Hospital. I'm also our lactation consultant, and we actually don't have a lactation program as of yet, but we're building it as we speak during our process. But so it's kind of cool. We have a 9-bed LDRP here on our unit. We do about 60 to 70 deliveries per month. Our moms do, occasionally we will transfer moms across to our postpartum overflow area, but for the most part our moms do stay in labor, deliver, recovery, and they continue their entire stay here on our unit. Currently, we actually had a 91% rooming in rate for March, which I think is probably our highest rate. We're averaging about 88% or so so far, but things are going really well with rooming in. We actually really are enjoying it. But prior to rooming in, our babies, they really just kind of came back and forth to the nursery. They would come to the nursery for physician assessments, for nurses assessments. We were bringing babies in to transition after deliveries, and they'd stay in there for, you know, anywhere from 2 to 4 hours, depending on who the nurse was and how long she wanted to hang on to that baby. And then as we started the rooming in process, one of our, you know, the nurses here were actually embraced it pretty good for the most part during the daytime. Our nighttime nurses took a little bit longer to really be on board with it, you know, because they were worried about moms being tired and that kind of thing at night. But things are really going well with that now. But for the day shift nurses, we usually only have a couple of nurses in the nursery at a time, and when you have some babies out on the floor and some babies in the nursery that are assigned to you, it makes it really difficult to take care of everybody. Because you're always having to find somebody to sit in the nursery. So it's really nice when all the babies are out and you actually have freedom to move about the unit and check in on everybody. Our physicians took a little bit more convincing for some of them. We had a few that were really on board and were able to go to the rooms. We still have a couple of physicians that we're working on that they want the babies to come to the nursery for their initial exam and for their discharge exam, and then they'll see them in between for that. But we have, before, you know, they had made a compromise with our physicians that were doing that we only allow them to have one baby at a time. And so those physicians are beginning to move towards actually seeing those babies in the room. But so that is getting better for us. And some of the things that we did as far as getting rooming in started, we just really tried to educate our nurses on the benefits of keeping moms and babies together. And when our patients come for tours, when we do our prenatal classes, we let them know that our babies are staying in the room with them now. When they come in for labor, we talk about rooming in, and after delivery, we talk more about it. And we really just kind of tell our moms that we reserve the nursery for sick babies now, and that all of our babies will stay with moms, and that's getting really good with that. And you know, we just really try to work on strategies together with our staff, and you say, you know, what are you doing to help make this go better? So we really like to bounce ideas off of each other. And I've really seen that here at our hospital, that it's really starting to become our culture. You know, we have a lot of patients that come in and say, oh, I want my baby to stay with me the entire time, and we tell them, well, you're in luck, because that's what we're doing now. And so rooming in has really gone well, and our patients really, really enjoy it, especially the ones that have had babies in the past that didn't get to room in, and now their babies stay with them, and it really has made a difference in their experiences. That's all I have.
All right, thank you so much, Susan. I'm turning things over to Shannon now.
Hi, my name is Shannon Grosh, and I'm one of the lactation consultants at Toro Infirmary in New Orleans, Louisiana. We are the second largest birthing facility in the state, and we have roughly between 250 and 300 births a month. So we were designated a gift hospital in October of 2016. The GIFT is a program for Louisiana birthing facilities, and it's designed to increase breastfeeding rates and hospital success. And it's basically following the 10 steps to successful breastfeeding. And it was a good platform for us to, you know, to reach, to then strive to become a baby-friendly hospital. We recently had our site visit for Baby Friendly March 28th and 29th of this year. We're very excited, and we should be hearing about our designation soon, so we're really excited about that. And this is a picture of our team, and that was when we had received our gift designation. So this is a photo of our family birthing center, the waiting area, and our rooming in rate is somewhere between consistently 85 to 90%. So initially, when we introduced rooming in to the staff and to the physicians, we changed the wording a little bit, and we called rooming in no separation. We began practicing rooming in January of 2016, and we involved the staff with, you know, educating the nurses, the nurse techs, secretaries, everybody, you know, across the board received education. The physicians, of course, and then we also went into the prenatal clinics of the physicians who are privileged to deliver at Toro. So although we don't own our clinics, we went into those clinics and educated their staff and their physicians, and even sitting in the waiting room, educating their patients with group discussions on the 10 steps to successful breastfeeding, which was including rooming in. And so that education started prenatally and also in our classes, our prenatal classes and our lactation classes. Why no separation? Well, for some reason, the wording was a big deal for us. It was introduced as no separation because our baby-friendly team felt that the verbiage was important for our physicians and staff buy-in. After speaking to the doctors and the staff, a lot of the physicians had, for some reason, they had a negative connotation of the term rooming in. They thought that we were forcing the moms to keep their babies in their room, and for whatever reason, their babies were going to get less nursing support because the moms were going to have to take care of the babies. And there was just this huge misconception about rooming in, and so they couldn't see the beauty of it. So we started calling, in the beginning, rooming in, no separation. And something as small as changing the verbiage resulted in physician support and physician buy-in. So the term helped us gain support of the physicians and the staff, although the concept was exactly the same as rooming in. And if you talk about rooming in today at Toro, we call it rooming in. For some reason, just that verbiage, for just that short introduction time, it helped us. So Toro's nursery, so you can look at the picture of this nursery, and that is what our nursery looks like. There are no babies in the nursery. We did not technically close our nursery when we implemented rooming in. The staff were instructed to encourage the mom to room in and explain the benefits of rooming in. And if the mom wanted her baby to go to the nursery, after the benefits of rooming in were explained, the nurses were instructed to support the mother, to take the baby to the nursery, and then to chart that she educated the mother on the benefits of rooming in. The nurses would bring the babies out for feeding if they were in the nursery. And so the great part of keeping our nursery is, you know, it is an option if a mother is unable for whatever reason to care for her baby. But I can tell you that having a nursery has not impacted our rooming in rates because our rates are really good. So having the nursery is just, it's somewhere for the babies to go, if the mothers can't care for their babies for whatever reason, but it's really an empty nursery. So our plan started with staff education. So we introduced rooming in at our baby-friendly kickoff. It was January 2016. It was mandatory for all maternal child staff. We showed a slideshow, and these are the slides that you see here that we used in our presentation. So the staff, they were receptive, and from the beginning. The pediatricians, not all of them were, but they are now. So that's what kind of, it was a road of really, of the main thing was educating and really focusing on those physicians that were supportive and were supportive of baby-friendly and rooming in. And then eventually the other physicians got on board. And the ones you would least expect, they got on board. So we were really happy about that. So then the non-clinical staff. We have a breastfeeding support and education PowerPoint that is just very basic, talks about the 10 steps. It's maybe 5 slides. And so all of the non-clinical staff, that includes hearing screen, the picture lady, they all had to watch this PowerPoint. And, the reason why we went to just everybody, even housekeeping, was because, you know, for instance, we didn't want, you know, the picture lady taking the baby out of the room or sticking a pacifier in the baby's mouth because she's trying to get a good picture. So we needed everybody to be on board with baby-friendly and, of course, you know, rooming in. So then we also, what helped us was the baby-friendly education for the nurses that was required of the 15 hours of online training. They did LER and Cofective, which taught about rooming in, and the 5 hours of hands-on education, which at Toro, we took that to, you know, another level. So we had the nurses, every nurse, which was probably close to 200, shadow the lactation consultant for one shift, and it was really a 5 to 8 hour shift. Then we held 2 mandatory 5-hour skills fairs and preparing for baby friendly, and we educated there on the benefits and importance of rooming in. And then we had 2 mock baby friendly assessments where, and I'll talk about that in a second, where we assessed the nurses and patients' knowledge of rooming in. So, you know, everybody, we wanted to make sure everybody was on board and well educated. We used the CHAMPS staff interview tip sheet. So I had those laminated on rings in the nursery. And then I also kind of consolidated that into a little pocket card that the nurses put in their pocket. So there was information, obviously, on there about the benefits of rooming in. So we wanted to make sure that the nurses could speak to that and that they could educate their patients. So we would randomly, you know, go around to the unit and ask baby-friendly questions, and one of those questions being about the benefits of rooming in. So the CHAMPS interview tip sheet was great. That helped a lot with educating about, you know, the 10 steps, including rooming in. We also used the Baby-Friendly USA audit tools. Those were really amazing. They were used to assess the nurses' knowledge of the 10 steps. The rooming in portion of the audit tools asks, why is rooming in important for breastfeeding? And then the evaluation part is, did the staff member know the importance of rooming in? So we had one of our nurse educators randomly pull aside every week 5 nurses, and she would use this step 2 of the audit tools with the nurses and just, you know, ask the questions. So that way, you know, we were sure that we were ready for baby friendly and that the nurses were well prepared and that, you know, obviously is rooming in. We held monthly staff meetings. We reviewed the benefits of rooming in those staff meetings, and we also reviewed the audit tool results to let them know, you know, where, you know, they are and their coworkers, and if, you know, they needed more education. We updated them on baby-friendly progress and the results of the most recent statistics regarding rooming in, skin-to-skin, initiation, and exclusivity. The staff meetings were held so on the night shift and day shift so that we could make sure that we, you know, got to everybody. The baby-friendly mock assessments that we would do, they mimicked an actual baby-friendly site assessment. We did one before CHAMPS came. We did one before baby-friendly came. Myself and other management acted as baby-friendly assessors. And so we would go and use these audit tools and ask the nurses about the benefits of rooming in. What would they say if their mother requested their baby go to the nursery? Where would they chart this? Like, just making sure that that they were well educated. And then also we interviewed the patients with those audit tools. And our assessment is over. You know, we've had our site assessment, but I can tell you that I still use these audit tools with the patients, especially to make sure that the nurses don't think that just because the site assessment is over, that they can stop doing the education. So, so if you haven't started using the audit tools, I would definitely recommend using those. And I made them a little bit more concise, just, you know, on one laminated, you know, sheet of paper, because they are a little bit cumbersome in my opinion, but they're good. And then we gave staff feedback on the areas of improvement. So minor procedures we do in the patient's room, like I said, the hearing screen, pictures, weight, and 24-hour assessment. The pediatrician's exams, those are done in the patient's rooms. We got new otoscopes, ophthalmoscopes. We purchased exam lights for the physicians to use in the room. We started with the physicians, and again, I said this earlier, who were the most receptive to baby-friendly and who were the most receptive to rooming in. And I learned very fast that I was going to pick my battles. The one or two pediatricians that were not receptive eventually followed, because then it just became the norm of how we do things at Touro. And, you know, the more I felt that we would push them, the more that they would pull back. So we left those couple alone, and they definitely followed and are seeing their babies in the patient's room. Every now and then they'll request a baby to go into the nursery for an exam, and when that happens, the nurses have been instructed to bring one baby in at a time, so that becomes very inconvenient for a pediatrician to sit and wait. So it's much faster and more efficient for them to go to their room. Documentation, the staff charting was an issue with rooming in, because we didn't have Epic at the time, so I was basically combing through charts and, you know, actually reading, you know, the nurses' notes. Some were charting rooming in, you know, others, they would chart that the baby went to the nursery for a circumcision, but then she would forget to chart that the baby went back out. So we needed the staff to chart rooming in the same way. So we decided on charting by exception. So if there's no chart, which Baby Friendly was fine with that. If there's no charting of the location, it's assumed that the baby is in the room with the mother. And then the charting by exception is just if the baby has to go to the nursery for whatever reason, that's documented, but otherwise it's assumed that the baby is in the room with the mother. So, you know, I periodically have done the chart audit, and especially for statistics. And I think the main thing is that the nurses, you know, they need to be held accountable for the inaccurate charting. So I needed to be able to go, you know, because I was the one that was doing the chart audits, to be able to go to management and say, you know, I'm having an issue with, you know, whatever nurse with charting, and, you know, I really needed them to back me. And they did. So that was good. And then, I don't know, Laura, how much time that we have for this, but I had talked about earlier going into the prenatal clinic. Laura, do you want me to go into that at all?
Yeah, a few minutes, and then we'll have about 10 minutes for questions.
Okay. So, so we realized that the patients were needing more education prenatally. I started using the audit tools in 2016, and the patient had no idea about skin-to-skin rooming in the 10 steps. So I met with the prenatal clinics of the physicians who are privileged to deliver at Toro. I showed them a PowerPoint explaining the education plan for the clinic. And I, basically started with that We're Prepared checklist from Cofective, introduced that to the clinic staff and said this is going to be, the basis for the education. The We're Prepared checklist educates on keeping baby close and continued skin to skin. So I developed these color-coded folders, and I've actually got the idea, Ochsner West Bank had started using these folders, and each of the folders represents a different topic for baby friendly. So if the mother is 12 to 16 weeks, then she's going to pull from the blue folder that's labeled 12 to 16 weeks, and she's going to get that We're Prepared checklist. And then she also, at that time, is going to get from the red folder information about skin to skin. So since she has those 2 sheets of paper with her, with the education, she can show her physician, and her physician can talk about skin to skin, or is she prepared? And so you'll see at 16 to 20 weeks, she will pull from the purple folder, and that discusses keeping baby close or rooming in. So by the time that mom is 35 to 40 weeks, she will have gotten all the education on the 10 steps. So that way we know that everybody has gotten the same information, and those mothers are prepared to come in and to deliver their babies, and there's no, confusion with why her baby is, not being taken to the nursery, because, we don't routinely do that. Like, the mothers are well aware of that. And then you can see on this We're Prepared checklist, like the red is Fall in Love, which talks about skin to skin. So the folder corresponds with the We're Prepared checklist. So the red folder is about skin to skin. So I try to kind of correspond that. So I think that, concluding this, that it's very important to introduce rooming in or no separation, in a non-threatening manner to the staff, to get the staff and the physician to buy in. It requires, educating clinical and non-clinical, prenatally and in the hospital, and the physicians beginning in the clinics. And then that education continues to the hospital. Teaching patients about rooming in prenatally helps, because then they often request their babies to stay with them. So that really helps, because there was a couple of pediatricians who wanted their babies, brought to the nursery in the beginning to have their assessment. Well, because the patients learned about rooming in prenatally, when the physician, the pediatricians would request the babies to go to the nursery, the patients would say, well, I thought that they said that my baby could stay with me. So then they were asking the pediatrician. So that helps a lot with any reluctant physicians. So again, we just learned to pick your battles, get the most receptive physicians on board, and then the rest will eventually follow. And that's it.
Great. Thank you so much, Shannon. So we have 4. I know you all listened to those presentations. I hope you enjoyed them as much as I did. There are 4 experts on rooming in here on the call to answer any questions that you guys have about what they already spoke about, or if they didn't cover something and you'd like to ask a question about that in terms of rooming in. That would be great. We have one question from the chat box that I will read now, and then if you feel more comfortable writing your questions into the chat box, feel free to do that, or we can open it up and people can ask questions in just a moment. So the first question we have is rooming in audited with a sample size or a 100% chart audit? So could one of you speak to how you kind of did your rooming in audits at the hospital?
So as far as at Toro, monthly, we would take a sample size of 20%. So I would take about, somewhere between 40 and 60 charts and do chart audits that way. The closer we got to our baby-friendly site visits, it was really those couple of months before, it was 100%. I even, would go to work on the night shift just to see how they were doing things, because a lot of times, that's when issues with rooming in come up, is at night. So the actual chart audits, though, they were 100%. Maybe it was 2 to 3 months before, it was 100%. But, as far as at Toro, we felt like it was really important that the person that was, spearheading the baby-friendly journey and, making sure that all of this was happening the correct way, that person wasn't in staffing. Like, I was not seeing patients. I mean, I was really educating and really combing through those charts.
Great, thank you. Linda, I know you guys, you're a smaller hospital than Toro, so maybe you can speak. For small hospitals, do you do a 100% audit, or do you choose a sample of patients each month?
We're sampling right now. It's very, we have an issue because of the resources that we have available. So we are sampling 10 audits a month from the 50 deliveries that we do. That's currently, so we would like to sample eventually 100% prior to our site visit.
Great, great. So I'm going to open it up to other questions from the audience. Again, if you put yourself on mute, pressing *6, you press #6 to unmute. So any questions from the audience? Well, I definitely have a question for you guys. I know so many of our hospitals struggle with having moms keep their babies at night, just because it's been a kind of the culture, the common practice in the past to send babies back to the nursery at night. So what are some of the things that your nurses, how do they talk to moms about this, or, how do they explain rooming in a way that makes moms feel comfortable keeping their babies at night? Maybe Alice Cheney, if you want to answer this question first.
I think for us, the biggest thing has just been to let mom know that we're here to support her. I know that someone else spoke about, not doing away with the nursery. And again, I think just for moms, that's a comfort factor for them to know that if you are completely exhausted and you cannot take care of your baby, we do have a nursery that your baby could go to. However, we are here. We will support you and encourage you, throughout the night. We're going to be coming in to check on you, check on your baby. If at any time you're concerned, please, press out on the call light and we'll come in to check on you. So I think once they know that you're there to help them and to support them, they're not as terrified of having that baby. Kind of like what the last presenter was saying, the no separation and the rooming in. I think it's just an education, a lack of education for the moms, because I think what some of our our customers think is that we're just going to dump the baby in there with them and we're a self-serve unit and you've got to take care of yourself. So as long as they know that you are here to help them and to teach them and to help them with their baby, that has been really beneficial for us and for our patients.
Great.
This is Linda. I'll just piggyback off of that and just say that we've increased our we do hourly rounding. So if it's not a labor and delivery nurse or a special care nursery nurse in there with the couplet, it is an OB tech that's possibly going in and checking on them. So there is that reinforcement that they are supported and that that we're here if they need us. That's been instrumental for us.
Yeah, and I agree. This is Shannon from Florida. I agree, with that. And then, oftentimes what I found in talking to the patients and after talking to the nurses, and the night shift nurses, they're amazing. But a lot of the night shift nurses, they fall into habit and how we've always done things. And so, a lot of our issue with rooming in at night, it was really more about the nurses than it was the patients, to be honest with you. And so it was educating the nurses at night, but then holding them accountable too. And then when they would hear that, we are talking to the patients during the day and using those audit tools, then they knew that whether rooming in was something they believed in or not, this is how we do things at Toro. You'll be held accountable if you don't support that. And so that was our biggest thing, I think, was getting the nurses on board, because the mothers they loved it. They were fine with it.
Great. So we have another question from the chat box. I think this one is a great question to ask. What infant safety measures have been put into place, or did your hospitals put in place to promote a safe sleep environment in the patient's rooms? And just thinking about safety in general for rooming in, what have you done? And maybe Susan, I know you haven't had a chance to answer yet. Do you want to try answering first?
Yeah, we do hourly rounding on our patients, and so that way, if mom's sleepy and you go in there and you see that she's, falling asleep with the baby, we can actually help her to put the baby in the bassinet right next to her. And I mean, that's really the biggest thing, is just making sure that somebody's always got their eyes. Also encouraging her to have a support person with her, so that way when she's resting, that that support person can help to watch the baby so that everybody stays safe.
Great. Any other, Shannon or Linda, do you have any kind of safety practices that you put in place or things that you do to promote safe sleep?
It's really sorry, you go on.
Oh, no, go ahead.
I was just going to, it's basically the same. It's the education, and it's the constant hourly rounding that let them know that you're constantly there to support them. And then if there are moms that are, accidentally sleeping with their babies in their arms, we're there to intervene with that as well. We have not had a baby fall or anything, which is great. One of our sister hospitals has had an issue with that. But we have not here at Olive Branch because of the hourly rounding and the constant interaction.
And I was going to say the same thing. We also do hourly rounding as well. We encourage moms to have a champion with her. And then also, as far as rooming in goes, we tell our moms that nobody's going to keep a closer eye on their baby than a mother. So it really is, safest for a mom to have her baby right next to her, because she is going to recognize hunger cues, or she's got her eye on that baby constantly. If something's going on, she will recognize that before anybody else would. So that, that always helps in talking to moms about rooming in. But as far as making sure that the couplet is safe, we do the hourly rounding.
Great. Thank you so much. So we are up on the hour, but if there's one last question, let's see, does anyone have, we have one more. This will be the final question. It's from the chat box. Did anyone implement quiet time to help moms with breast?
We haven't at Toro, but that is definitely on our radar because I've heard that is absolutely amazing. So we haven't, but I'd love to hear from another hospital if they have.
I would like to hear the same. We haven't at Olive Branch as well.
Okay. Susan, have you?
So we don't have quiet time here, but that is something that, as a matter of fact, we were talking about most recently. So that's kind of one of those things we're throwing out there to hopefully maybe implement.
Yeah, I know Women's Hospital, Merit Health Women's recently implemented, or they've had quiet time. They had it at a set hour every day, but actually they just changed it to letting the moms decide when their quiet time is and then just putting kind of a little flyer up on the door whenever the moms choose to have their quiet time, just because of the added flexibility for parents. But they seemed to like that. All right, so we're up on the end of the hour. I wish we could spend more time talking about rooming in. You guys had some great questions. I'm going to wrap things up, but I just want to thank our presenters again for sharing with us. We really appreciate it. And we look forward to talking to you all in June for our the final webinar in our spring series. Thank you and have a good day.